All right, today on Life on Purpose, we're joined by Dr. Matt Fontaine, chiropractor, movement specialist, and author of the new book, Only One Body, Your Owner's Manual for Optimal Health and Peak Performance for Life. Dr. Fontaine has spent more than 2 decades helping people rethink the way they move, heal, and care for the only body they'll ever have. In a world where burnout is normal, injuries are brushed off, and most of us aren't listening to what our bodies are trying to say, Dr. Fontaine brings a refreshing, empowering perspective and practical guide to optimal health and performance, focusing on building the right healthcare team and making informed lifestyle choices for long-term wellness. In this conversation, we will dig into why so many of us are living out of alignment physically, mentally, and purposefully, and what it actually looks like to come back home to ourselves. We will discuss ways to become your body's master, making sense of overwhelming medical information and ways to filter out what won't serve you. We will hone in on how honoring your body can unlock a deeper sense of meaning and connection in your life so you can operate with peak performance. This is a conversation about resilience, agency, and taking responsibility for your well being, not from a place of confusion, but from a place of empowering possibility. So let's dive in with Dr. Matt Fontaine. Welcome.
Thanks, Brandy. Thanks for having me. Honored to be here.
Absolutely. So I was able to skim through your new book. Unfortunately, I was not able to read the whole thing before we got this interview booked. But there's a lot of useful information in there. And I think, when I think back to um, kind of when I was really shifting how I looked at my health and healthcare based on some, health issues that I ran into. This is a book I probably would have loved and needed at that time. So let's talk a little bit about why you decided to write this.
Yeah, so I think I probably really started putting the ideas together over 10 years ago. And it really just grew organically out of conversations with patients, right? So after your first few years in practice, you start to get some, wind underneath your wings and you
Right.
start realizing just how much people are in the dark. They just don't know what they don't know even. And so it became pretty obvious that most of us are out there operating without an owner's manual, and we're not getting the information we should be getting from our doctors. Sadly, there's just a lot of siloed, there's still a lot of siloed information. Doctors are not communicating with other doctors. You've got, people that just have old school grin and bear it mentality. And the general population is not keeping up with the science and innovation that's happening in the professional sports arena and just best practices in healthcare in general. So that was kind of the crux of, starting to do a blog post way back when. And most of the articles we put out just came from conversations that popped up in clinic with patients day to day.
So real
Um,
life, day to day, real life experience, kind of.
Yeah, patients coming in, the problems we see day in and day out. We're not
Mhm.
writing articles about one-offs or things that are just, rainbows and unicorns. We're actually writing things that are just affecting the masses,
Yeah.
things that are recurring themes. And so that
What were
generated a
some of
ton of
those recurring
content.
themes?
A little freeze up there.
Oh, there we go.
All
What were
right.
some of those recurring themes?
I mean, everything from just, basic neck and back pain,
Mhm.
repetitive motion injuries, the impacts of posture, the importance of exercise. How do I exercise? Why do I need to move? All these different things that cause people to get into the what I call the belly of the beast. They go to their primary care doctor for knee pain. Probably not the best place to start. If you have knee pain, you know it. You probably belong in a physical therapist office or a sports chiropractor. Let's start there, get a good evaluation of what's going on. And then those providers, if they're competent, should be able to make the appropriate referral when needed. When to order x-ray or MRI. When do I need to see an orthopedic surgeon? And what ends up happening is we go down the route of primary care. These doctors are being forced to see a myriad of conditions, many of which don't fall into their circle of competence. So we end up seeing patients sent to pain management too early, sent for
Mm.
inappropriate imaging too early, or they're sent to an orthopedic right out of the gate when really they're not a surgical candidate. So that's kind of just a high level in a nutshell of what the type of things that we tend to see. Being a sports chiropractor, our practice has always been focused around spine care, obviously, but extremities. So it's musculoskeletal focused, and 1 in 3 visits to a primary care doctor are for a musculoskeletal complaint, and we're just not providing these patients with good resolution.
That's interesting. So, where's the communication breakdown, I guess, as far as, you go to your primary care that they wouldn't think first to me, hey, why don't you go see physical therapy, chiropractic, etc.
Right.
I find one of the biggest issues is kind of the compartmentalization of the healthcare system where you're working on individual systems and nobody's
Right.
really talking.
That's right. As medicine has become highly specialized and
Yeah.
evolved, it's become more siloed. And unfortunately, primary care kind of sat right in the face of that storm where when managed care really took over in the into the 90s and early 2000s, we've put a lot of onus on primary care doctors to become specialists in a generalized world.
Mhm.
And they're having to triage and make referrals. And a lot of times they're beholden to restrictions with the insurance companies and they can't get the testing they want to do or they can't get the appropriate referrals. So they fall into the realm of just prescribing anti-inflammatories right out of the gate, probably quick to pull the trigger on a referral for physical therapy. And now it depends on what kind of a therapist do you get, if you're getting any resolution. So we're really asking them to see, again, a third of their visits in an area they're not well trained for. And I don't mean to throw primary care docs under the bus. These are amazing doctors. They have the best intentions. But we're asking them to handle musculoskeletal care at a level that really requires a specialist. And that's one of the biggest problems that I see is there's not good communication. When we look at physical medicine as a field, it really encompasses a lot of different specialties from orthopedic and neurosurgery, chiropractic, sports chiropractic, physical therapy, acupuncture, massage, nutrition, functional medicine, movement coaching. All of these things are really what's required to have a truly integrated physical medicine specialty.
Right.
And we just aren't seeing enough doctors out there connecting the dots for these patients.
Well, I was sitting here thinking as you're listing all those off, how wonderful it would be if all of that was all in one building. You know,
Yeah, yeah.
if
And
there was,
there are places that are doing a pretty good job of it.
yeah,
Um, that are what I would consider integrative. It's very, very rare to find a group or a practice group that has everything. For
right.
instance, a lot of times they have a lot of those things, but they don't have chiropractic. So I would make the argument if you don't have chiropractic, you're missing a huge facet
Right.
of, the physical medicine realm, especially dealing with the structural component.
Hmm.
And we can get into the triad of health where we talk about structural, chemical, emotional, but structural alignment in the body is a fundamental to our optimal health that has to be addressed. And unfortunately, we're just not addressing it outside of the arena of chiropractic care, which a lot of these integrated clinics fail to offer as a line of services.
What's the reason? Is it because it is such a quote unquote new
And
area
it's not
of?
new. I mean, if you look at how medicine came up, back in the day, if we go
Mhm.
back 100 years, you had
Mhm.
DO, MD, and DC.
Mhm.
And what ended up happening is in the age of big pharma, and especially in the 50s and 60s with the Veterans Administration, they really brought DOs into the world of drugs and surgery. If we
Right.
look at osteopaths today, certainly a good number of them go into primary care, but less and less year over year. More and
Mhm.
more of them are going into surgical specialties. You'll see a lot of osteopaths go into PM&R, physical medicine and rehab, so pain management, which is an amazing field. We're making great breakthroughs in how we manage pain. Um,
Without
so
drugs,
really,
you mean?
chiropractic is not new. It's been around forever.
Mhm.
And I would argue it's a combination of just the routine and medicine has always had a really good relationship with physical therapy. That's that standard referral from a primary care to a physical therapist for 3 to 4 to 6 weeks, and then down the ortho route. Um, and integrating with chiropractic care outside of a large medical group that's really integrated. We're just not seeing that happen as much. The really progressive docs out there recognize the need for it. They recognize the efficiency of it, how effective it is.
Hmm.
In the insurance industry, they talk about triple aim. It's cost effectiveness of care, the overall effectiveness of the treatment, and patient satisfaction. And in the end, when you look at the big insurance carriers, they really don't care about that. They say they do, but reimbursement rates keep going down year over year. The system is rigged. And in a perfect world, we would be making those referrals to the appropriate conservative treatment providers because that's a wiser place to start. It's more cost effective. And then we escalate as we need to.
I see more and more healthcare providers going more of a concierge route, like subscription-based
Mhm.
healthcare and bypassing insurance
Yes.
altogether. What are the pitfalls and the benefits of doing something like that?
Well, for one, you have to look at financials. A lot of people are going to want to use their insurance, and I get it. They're paying
Right.
high premiums. The benefit to a concierge practice is we're not beholden to that. But there is an up, you have to pay. It's a membership based
Yeah.
um, type of practice. And I would argue that the people who are really prioritizing their health, they tend to
Hmm.
be healthier.
Hmm.
They're probably okay spending $2,000 a year for a membership to have VIP service. They can
Yeah.
get a hold of a physician either via phone, telemed, or an email. Um, Generally speaking, they know that they're going to be doing preemptive things. They're getting their annual physical, they're doing blood work. They're not waiting for a crisis to occur.
Right.
Whereas most people in the United States today, if they have health insurance, they're underinsured, meaning they're
Hmm.
paying through the roof out of pocket.
Right.
But when they look at what their actual coverage is, they're really covered for catastrophic. They're going
Right.
to have to go out of pocket if they have a acute case of low back or neck pain, including even if they have to have surgery, high deductibles. So the benefit to these concierge practices is twofold. It allows the doctors to not have to focus on seeing as many patient visits a day, a week,
Mhm.
because that becomes a numbers game. And at some tipping point, we start to deplete the quality of care. So in a concierge practice, hopefully the doctors are able to spend more time with the patient, which should lead to better outcomes. Because over the last 2+ decades, we've been asking doctors to see more and more patients to where it's diminishing return. Most people realize their healthcare is way more specialized than they can get in a 5-minute visit with a physician. And they're just
Right.
being forced out the door with a couple of prescriptions. There's not a lot of follow-up. And I would argue in these concierge practices, we're getting back more towards the high touch of what medicine should be. And that's the patient interaction.
I agree with that, and it's interesting that it had to kind of reach a tipping point for people to be like, I can't, this is not working. It has to change. And I think we're still in that growing pains area. We're not quite there, but it is nice to see. I mean, I've interviewed many practitioners, doctors from all different areas on this show, and it seems like we're heading more and more in that direction. And I hope we get there, and I hope more traditional physicians will jump on board also. I mean, I interviewed my own doctor a few episodes ago who left emergency medicine after almost 40 years and opened an integrative clinic because it just
Yes.
he couldn't do it anymore. He wasn't able to give the care that he knew he wanted and needed and the patients wanted and needed.
Right. I mean, healthcare providers in general, they go into the field because they're healers.
Right.
And the system is rigged against us.
Correct.
And so you're seeing that a lot. I mean, the first concierge practice I saw was in 2002, 2003,
Hmm.
and it was a unicorn. You didn't see a lot of this, but the writing was on the wall. These
Right.
are doctors that just didn't want to play the game anymore. They wanted to be beholden to a smaller number of patients, higher quality of care, more high
Yes.
touch. And unfortunately, that comes with an out-of-pocket expense because the insurance companies just aren't going to prioritize that. Um, it's a trend that's growing, and you're starting to see. these integrated practice units, and it sounds like a one-stop shop for healthcare.
Yeah.
It's very difficult to pull those off and really have every specialty represented and to have all of those specialties communicating and collaborating with each other. Um, you are starting to see it a little bit more, especially in the VA system. We're starting to see, I mean, they've had chiropractic in there for
Right.
I think over a decade now. And the challenge really though is the frequency that veterans can get in and see the chiropractor because there's such a paucity of providers that the demand just far outweighs the supply. People are only able to get in and see the chiropractor once every 6 to 8 weeks. And that's maybe okay if you're looking for just preventative maintenance care. But if you have an acute issue, or in
Hmm.
the case of the veterans, a lot of these veterans, they've got chronic debilitating impairments that require way more frequent treatment than once every 8 weeks.
So you have too few providers and too many vets needing their services. Is that what you're saying?
Yeah, I would argue that's true throughout the Veterans Administration. Particularly, it's true with certain specialties, including chiropractic.
Okay, okay. So
Yeah.
you have a background of working with vets. I want to circle back to that just a little bit because your area of patients is you've worked with veterans, professional athletes, a whole spectrum. Um, the area of working with vets, though. We just celebrated Veterans Day. There's obviously a need in that area for all kinds of specialties. Can you speak to that just a little bit more?
Yeah, I mean, it's good that we're offering chiropractic care, and now through community care, the Veterans Administration is allowing veterans to go outside of VA hospitals.
Hmm.
Again, it's a supply and demand thing, and so they're able to go see a credentialed chiropractic physician out in the community if they're participating with the Veterans Administration. So I think we're making strides to provide the care that we've always promised our veterans.
Hmm.
And a lot of times, sadly, we fall short. And a lot of it, again, it comes down to big bureaucracy.
A lot of red tape.
And we've got a lot of veterans in this country, and we've
Right.
been fighting wars for over 2 decades now. And so the providers that I've met in the Veterans Administration are amazing. They're doing the very best they can for these patients. So I think it's great that we're now enabling veterans to go outside of the system. And it's not just for chiropractic care. If the VA
Sure.
can't provide a subspecialty, they will work to find a provider in the local community to get the veteran the care that they need.
Okay. Okay. Um, so let's touch on just a little bit of the spectrum of your career.
Sure.
Um, take me back to the beginning. Obviously, starting out in practice, but then you end up working with all kinds of different groups of people. Um, how did that arc happen?
Uh, I originally got out of school and was fortunate enough to be invited to go do a residency at Texas Back Institute, and it's a surgical level one research center. They train spine surgeons there, cutting edge surgery. That was my first exposure to real integrative care. And we
Hmm.
had orthopedic surgery, we had scoliosis corrective surgery, you had pain management, you had physical therapy, occupational therapy, you had chiropractic, we had behavioral medicine, which was
Okay.
the first time I was exposed to, when you have patients that are in chronic pain, we know today that chronic pain can rewire the brain. So it's important to have that behavioral medicine aspect to deal with patients to understand that pain outlasts the injury in chronic pain cases. And so while you can make a full structural recovery, the hard and soft tissues of the body can do really well post-surgery.
Hmm.
Central sensitization, where the body just becomes sensitized because they've been in chronic pain for so long. And there's things like reflex sympathetic dystrophy, and there's all kinds of things coming out in the pain management world over the last 2 decades that we're doing a much better job of managing chronic pain because not all chronic pain is due to an injury that hasn't fully recovered. And so that was really my first exposure to truly integrative care. And quite honestly, it's really difficult to see that and then to go and revert back away from it to just get into a private practice where you
So
don't
you know
have.
what's possible, and then it's not coming into the
Right.
real world.
Right. So when I got into practice in Florida, I was working with an established group, small physician practice. Uh, I made it my priority to go out and meet the best of the best in the area in the fields of orthopedic surgery, pain management. At the time, early 2000s, regenerative medicine was kind of a new thing, and it was really only happening at the elite pro level athlete area.
Hmm.
Um, but certainly going out and meeting primary care doctors and um, endocrinologists, because patients come in and they have coexisting things. So
Right.
I had to build that integrative, collaborative group outside the walls of my clinic. And so
Hmm.
over time, you become an expert at connecting the dots for people because
Sure.
you'll send them out to a specialist, they'll come back and report back to you, and they didn't get the answers to the questions that they had. So then it became my job to be the gatekeeper.
Right.
Then I was fortunate enough to get trained with active release techniques, which is a soft tissue treatment that's been around since the mid 90s. And it really caught a lot of traction in the Ironman triathlon world. Active release became a medical partner, and I was able to work on the active release Ironman medical team. So that was
Wow.
amazing. I saw a
Yeah.
lot of amazing athletes.
What an experience.
Yeah, everything from the pro athlete to the weekend warrior. I mean, if you're an Ironman and you're running a full-time job and you're a mom or a dad, um, you're basically running a
You're basically
pro athlete.
superhuman.
Yeah, you're superhuman. You're running a pro athlete schedule. And by the way, you got a full-time job and a family to take care of.
And kids
So
at home. Right.
uh, saw some amazing people. I met I think at the time in 2005, and I'll just say mid to late 70s, a nun, she's very well known. She's world class athlete. I met her at Ironman 70.3, which was the half world championships.
Wow.
So you meet these kind of people that are just amazing. And then I was fortunate enough to get invited into Major League Baseball. I did that for several years and then relocated to Virginia. And when I relocated to Virginia, I kind of rekindled my love for the military and veterans and being in that Washington, D.C. area.
Right.
The world's your oyster. There's a lot of
Mhm.
different military facilities to be able to work with, active duty veterans, other government agencies. And so you're really seeing people that are really out there on the tip of the spear,
Sure.
active hard chargers. They're getting broken down. The injuries they're sustaining, they compound over time.
Right.
It was really an amazing place to practice.
That's amazing. What an amazing career. Like I said, just the career arch when I was first reading your bio, all these different areas. And I'm just always so curious, how you end up in some of these arenas. Um, what so because athletics is a little bit of my realm, let's talk a little bit about athletes and what kind of work and maybe remedies we're seeing in that arena. And then I also have a question too about, you know, you're not exactly anti-surgery like a lot of docs would be. Preventative, obviously, but if it's necessary, obviously, we can go that route. So, and you see that a lot in athletics. We're going to try to prevent injury as much as possible. However, if surgery is necessary, we're obviously going to go in and do correctives. But let's talk about your time in athletics and what athletes are kind of seeing and dealing with, and how preventative care is extremely important.
Extremely important. Yeah, I would say I'm definitely not anti-surgery. I'm pro-surgery
Hmm.
when it's needed.
Okay.
So we'll obviously do whatever we can to try to keep people out of surgery. And when you look at the pro game and just elite level athletics, whether it's at the collegiate level, Olympics,
Right.
there's a lot of times when surgery is preemptively the thing to do
Hmm.
because the injuries have been so catastrophic or they've stacked over so many years.
Right.
And a perfect example of that is in Major League Baseball. I mean, if you're 21 years old and a high prospect pitcher and you haven't had Tommy John surgery
Right.
to replace the ulnar collateral ligament in your elbow, most of the trainers and coaches are pushing guys to go do that.
Yeah. I mean, my
depending
son, he's a
on,
17-year-old
that's right.
senior, and he's got friends who've already had that surgery. Yeah.
Yeah.
Hmm.
And there are surgeries like that where you could make the argument that the elbow is better post-surgical than it was beforehand. So, hey, why wait for it to tear completely? Let's just go in preemptively and we can start the rehab. You're younger now than you're going to be a year from now, so that makes
Yeah.
sense. Uh, for people who aren't getting paid millions of dollars a year and that's their full-time job, avoiding surgery is usually number one of their priorities
Yeah.
if we're even talking about it. So thankfully, the field of regenerative medicine has done an amazing job to fill that gap
Sure.
between patients who have um, small partial tears but are not quite there to the point of surgery, or they may just have other risk factors that are they're not good surgical candidates, but they're torn enough that conservative management, physical therapy, chiropractic alone, acupuncture is just not going to be enough.
Right.
And now we have things like platelet-rich plasma, stem cells, peptides.
Yeah.
This field over the last 20 plus years has blown up.
It's
And
kind of exciting. I
it's
know
very
that sounds
exciting
really
because,
nerdy, but
yeah, it's easy to geek out on it, but it's really exciting because now we've taken this field that really we're able to bridge that gap.
yeah.
They used to call it the Grand Canyon between, hey, I'm over here and I'm banged up, but I can probably rehab it. If you're in the middle of that canyon, what do we have that's going to really help to speed the body's natural repair mechanism and
Right.
also try to amplify it? And they're making amazing strides in regenerative medicine, and I've had countless patients go through it. I've had it done,
So have I.
elbow, shoulder, amazing
Yeah.
results. Um, the downside I can only think is just the out-of-pocket cost, and
Absolutely,
it's becoming
absolutely.
more
I
affordable.
interviewed a regenerative medicine doctor on this podcast. Actually, he did my stem cell treatment, um, and that is exactly right. That out of pocket cost is really the only downside.
Right.
Um, I mean, I was in and out in the same day. So
Yeah.
it's not, there's no downtime, nothing like that. So yeah, it's really interesting.
Yeah, I just, anytime we're dealing with finances in healthcare, I mean, it's not my job to, coach people on that, but I'll try to get them to, look at what's the quality of life
Right.
going to be if we don't intervene here and versus if we do something now. And so most groups have really good financial options to help make it accessible to
Sure.
most people.
Sure.
Um, but it's an amazing field. And I mean, I wouldn't want to go back to an era where I had to practice without it
Yeah.
because those patients before regenerative, you could only get them so far. And now we were just kind of putting band-aids on an arterial bleed. If
Right.
you're torn and broken to that point, and you're really not a good surgical candidate, what do you do?
Hmm.
And so now we have all kinds of modalities at our hand with, the combination of regenerative medicine and shockwave therapy and deep tissue laser, and you combine that with acupuncture and dry needling to
Yeah.
decongest areas and improve blood flow. It's really amazing to be able to connect these dots for people rather than just put people on anti-inflammatories and cortisone the rest of their life.
Not a good option.
We've
No.
seen how that plays out, and
Yeah.
it just doesn't end well.
No. And I think again, the important part is that people know that these are options, and they aren't being discussed. And perfect example, actually, and I'm going to try not to get frustrated when I tell this story, but it still frustrates the heck out of me. I was having a conversation with a specialist in his office about how I used stem cells in the past for, again, some chronic health issues that I have that I wasn't able to kind of get under control for various reasons. Um, and he practically laughed at me. He practically laughed at me and he's like, "Wait, who's even doing this? And what is their background?" Kind of just poo-pooing the whole the whole conversation. And I'm sitting here thinking like this is very popular in realms that I am in. Nobody would think to laugh at this or to shun it or shy away from it or anything like that. And it's just interesting to me how we're living kind of in this era of this information breakdown. And so if we've got a highly specialized physician who doesn't know that these tools are at their disposal or that they could refer them out or anything like that, then the everyday person certainly does not know about these options.
Right. And it's unfortunate when you see these physicians, and I've certainly come across a lot of them in my career.
Hmm.
They don't have a growth mindset. They
Sure.
probably stopped learning decades ago.
Or it's just not something that's in their specialty. And this was a highly specialized physician. And to be fair, and I'm
Yeah.
trying to be very generous here, um, I really, really do try to uh, not get too frustrated. Um, but gosh darn, you know?
Yeah, I think, it really comes down to uh, staying in your lane
Sure.
and recognizing, and, the more hyper specialized we get,
Yes.
we're living in our 3 foot world. And so for these specialists, when I make a referral for a patient, I know who they're going to see, and I know the
Mhm.
specialty, and I know what those physicians are capable of. And I also know the ones that are progressive, that are going to be able to talk about a wider base of knowledge and understand how everybody plays in the sandbox. Sadly, a lot of these really specialized providers, they live in like a 2 foot world. And so
Mhm.
maybe not the best person to have that conversation with, but certainly a primary care doctor, an
100%.
orthopedic surgeon should really be up to speed, at least understanding the lexicon behind platelet-rich plasma, stem cells. What is the difference? Is it adipose tissue?
Yeah.
Where are we getting the tissues from? Bone marrow grafts. Um, we need to keep an open mind, and when patients present something that they found online, and you'd never heard about it before,
Hmm.
uh, I think it's important to recognize if it's just not worth your time to investigate,
Yeah.
say to them, hey, I'm just not familiar with this. Maybe you want to have that discussion with one of your other physicians.
Yeah.
Or depending on the relationship you have with that patient, you may just say, let me get back to you on this. And then start to do some investigation, reach out to some providers in your area. I mean, if it's a pain management procedure, hopefully you have a pain management group you work with,
Right.
and you can get on the phone and reach out to somebody and say, hey, what are we doing with this new, radio frequency ablation or rhizotomy, where they're doing a lot of that in spine now, and it's not new. They've been doing it for a long time, where they're actually, cauterizing the sensory nerve as a way to manage chronic pain. I can't imagine a physician who's a primary care that hasn't heard of that.
Sure.
Um, but if patients are bringing things to your attention, I don't think it's the appropriate course of action to just downplay it.
Oh, it was,
Um,
yeah, it was
and you do see
infuriating.
that, well, I mentioned to my other doctor
Well,
that I was
especially
using.
because it had worked so well for me. Like it
Right.
changed my life. Literally changed my
Yeah.
life. I've,
Yeah.
I've had two treatments, separated by almost 6 years. And it was a game changer for me. And so it hurt a little bit. It stung for
Right.
sure. So I heard an interesting, uh, I can't remember what podcast I was listening to, but there was a statistic or something that had just come out. They were discussing with doctors, or they're polling doctors, like, what is your biggest complaint right now today in healthcare? And 80% said their biggest complaint was that patients are coming to them wanting integrative care, things that were completely out of their wheelhouse. They didn't want to talk about it, deal with it. They had all these questions and they were way more involved in their care. And it's throwing doctors for a loop.
Did this survey, was it primary care doctors, or was it just
I
random?
believe so. I believe it was primary care. So someone coming in for primary care and they're curious about integrative, like root cause medicine. They're
Right.
very, what is the
Right.
cause of this? I don't want you to just give me a prescription for my symptoms. What
Yeah.
is the root cause? And that was
Well,
their main complaint.
we are, Peter Attia talks about this, medicine 3.0,
Hmm.
and things are changing. And so it's a tall order, and I feel for the primary care doctors because
Sure.
that is a huge undertaking to be able to be knowledgeable
Well, and to
about when is a
shift.
patient a candidate for acupuncture. And I get it. When we start looking at, I mean, there's a functional medicine group that I work with
Hmm.
because when patients come in and I can tell this is systemic inflammation, it's not because they have a low back facet syndrome and they may have these biomechanical things concomitantly with something systemic.
Right.
And, you know, lots of things come to mind. It could be something that's like a fibromyalgia or pseudofibromyalgia, but at the end of the day, all roads lead to inflammation. And when a patient comes in and they've been having pain above and below the waist, front and back side of the body, they've got all these other different things, the best thing we can do for them is to get a good blood panel. And I mean a comprehensive blood panel and those are not cheap and they're not going to be covered by your insurance. Most comprehensive blood panel, if you go to your primary care and they do just a basic
Right.
Chem 24, you're not getting homocysteine levels checked.
Or
You're not,
CRP or anything like
that's
that.
right. You're not getting any of that. And so, um, I think, we're changing what we're asking doctors to do. And I get it. So my advice to a primary care doc would be to build that cadre of specialists around you and have a nutrition expert, a doctor of
Right.
clinical nutrition that you work with, not just a dietitian that's been dealing with diabetes forever. There's a huge need for that, but the
Sure.
average person out there who's not a diabetic, they need a
Their
clinical
needs are
nutrition,
different. Yeah.
and these primary care docs should really be building out their referral network. And in my
Yeah.
opinion, you should have 3 or 4 or 5 chiropractors that you know well, that
Hmm.
you've vetted, that are willing and able to play in the sandbox and, not be out there telling patients that, hey, you don't need medical intervention. We're going to cure everything from cancer to asthma to everybody has their place to sit at the table, so to speak. And if you have a primary care doctor that has all of these next steps in line and these people at the ready, that's an amazing primary care doctor who's progressive enough to say, yes, you want to get a little bit more into let's find out why are you having these symptoms, not just taking medications. It's going to take more than a few providers to come down with that diagnosis. And once you start having these doctors communicating, and by
Yes.
the way, it's okay if we disagree because it's discussion about what might really be going on.
Well,
Uh,
100%.
yeah, I
Yes. I
think
mean,
ego gets in
that
the way a
disagreement
lot.
is going to probably get you to the answer. That back and
Yeah.
forth, that because it leads to discussion.
If you think about, putting the patient first, patient centric, that really means putting your ego in check. We all want to play the hero. And when you realize, hey, I can't get this done alone, or we need help, we need to get some
Hmm.
other eyes on this.
Hmm.
I think the best docs, the most confident docs, welcome a second opinion because if you're confident in your diagnosis, then great. On the flip side, if you're unsure, get a second and a third opinion, bring some help in
Right.
and collaboratively come together because better outcomes are directly tied to a collaborative approach. In moderate to complex cases, certainly the simple things that come in day to day, a competent physician should be able to handle that, maybe
Sure.
with, some basic blood work or whatever. But, Americans are getting sicker and sicker every year. We're not getting better.
No.
And they're dealing with chronic conditions that sometimes it's just getting to the right 2 or 3 different providers.
Yeah.
If you have a TMJ case with headaches and you go see a chiropractor that's competent and they make a referral to a neuromuscular dentist, and maybe we get some acupuncture on board and we look at structure in the neck, we can do a lot to curtail that chronic headache, tension, neck, um, without having to go and really escalate to very expensive, healthcare procedures.
Right.
But I feel for these primary care docs because that is a scary situation when you have patients coming in, they're on Dr. Google. A patient who's
Hmm.
on the internet, they probably have as much education as a second year med student for that one condition they're researching, but
Right.
they don't have the context
Right.
to be able to say,
To piece
yeah,
it
it sounds like
together.
I have all these symptoms, but it's probably not. and here's why. So
Yeah.
I think we need to do a better job of educating primary care docs to collaborate on a higher level.
Sure.
It's
And I
just been,
think in general, like once you get past the, okay, this is frustrating, this is different than how I'm used to practicing, it might actually take some weight off of them if there
right.
is a team to refer out to. So let me ask you this then. Let's say a patient goes in primary care, and they are not working with a doctor that kind of has that referral system, those different areas to really refer to, and that's what a patient wants. How is one to create their team per se? Because that was
I
always
mean,
important for
that's,
me. I built a really great
yeah,
team, but there was a lot of trial and error. I have great, great practitioners. Great. I love it. But it took me forever to put
yeah,
that team together.
I don't think there's any shortcut. I think a great place to start is your primary care office,
Hmm.
and I remember when I was in Florida, I worked with a primary care group, and at the time I was probably 6, 7 years in practice, and I remember their referral binder.
Hmm.
I was blown away. I mean, they
Wow.
had 3 to 5 specialists for every known specialty under the sun.
Wow.
Most of these were doctors that they personally knew had been vetted. So that's best case scenario.
Hmm.
If you don't have that, man, I just don't know if there's any shortcuts. I mean, it took me a long time. Uh, Fortunately, when I came to Virginia, I had some friends that were in the surgical world, so you get to meet people quickly
Right.
that way. Being a physician helps because you can reach out and do that peer-to-peer thing.
Right.
As a patient, I mean, you're really beholden to your local community. Start
Hmm.
asking around. But, generally speaking, like I see it all the time with patients, somebody will come in, oh, so and so told me that I should have this done. I'm like, oh, great. Are they a nurse? Are they a nurse practitioner? No, just, my cousin or whatever. So,
Right.
yeah, just because Uncle Fred's had said issue doesn't make him an expert.
Right.
So it is very, very cumbersome for the patient out there to
Yeah.
put this group together. I think if let's say you're suffering with a chronic orthopedic thing, you might start asking around at your local gym, but it's very difficult. I mean, it takes years as a physician to really put these relationships in place.
Sure.
Um, and it's maybe one of the things that I would look to ask when I'm interviewing a new doctor. Who do you work with outside of just because we just can't be a one size fits all for everybody.
No, and I think we are to the point of realizing that one size fits all in medicine in general is not working very well for people. Especially since, like you said earlier, we are kind of in this chronic disease epidemic where, I mean, we have an overtaxed system that's not working. It doesn't mesh well with chronic disease, I guess is what I'm saying.
Right.
So
Yeah, we're failing.
what are we looking at here from your perspective? And I like to ask practitioners that come on to this show from your perspective, what has happened over the last few decades to explode this chronic disease epidemic? Because I think about, when I was a kid, my friends' parents were not, I mean, aches and pains, that kind of stuff. You would have the chronic or the periodic, ortho case, whatever.
Mhm.
But as far as like the explosion in autoimmune diseases and just chronic diseases, what are we looking at here?
Well, I think there's several legs to that stool. Number one is we are way more sedentary today than we ever were,
Hmm.
and that's a major problem. We're just not moving. Um, our food sources are highly processed and nutrient deplete, and we've got way more environmental exposures to toxins, everything from plastics to microplastics to xenoestrogens. I mean, and I'm not an expert in this field. I refer that out to the functional med group that I work with, but
Right.
we are being bombarded by a combination of lack of movement, poor food choices, environmental exposures, higher stress levels than we've ever had before.
Yeah.
And we're in the information age where we've got more information than we can handle. And so I think the combination of those things, when we look at the health triad, we always talk about structural, chemical, emotional, right? So the
Mhm.
structural being how well your body structure system is in alignment, how it moves, how dysfunctional is the movement, and then chemically is your biochemistry, the
Yeah.
hormonal endocrine systems of the body, how all our biochemical pathways work, and then lastly, the emotional, which I would argue that's physical, that's mental and emotional, uh, fitness, readiness. We're more and more stressed. We're being
Yeah.
asked to do more and more on a day-to-day basis. We're not sleeping well. So when you look at most Americans today, they've got at least two of those three things that are dysfunctional, if not all three.
Yeah.
Um, and I don't think we're making the appropriate connection for people that if we start to get better structural alignment, that goes a long way to helping to impact the other two sides of the triangle. And if we bring in a functional medicine group and we're starting to look at these things, then we can start really getting down a path to more optimal health. But that's
Right.
really, I think, at a high level, what's driving most of this. And we can talk about inflammation all day long. And yes,
Hmm.
it is probably the single biggest driver in everything from chronic disease, cancer. Um, we have to look at how do we mitigate that inflammation?
Right. So once you get that under control, let's cool that off just a little bit. But then we've got all this other work that we need to do, diet,
Right,
movement,
right.
emotional health, all of that. That can be really overwhelming for a patient who has spent their entire life maybe not focused on those things.
That's right.
And I think I've got three children. My husband and I have three children, two in high school and then one elementary school. And it's been really important for us to start those conversations right now. So they get really annoyed. I don't care. They get
Yes.
really annoyed. But it needs to be something that they have in the back of their mind to focus on as they go through their life so that we can kind of mitigate
Right.
some of these chronic issues. They're not perfect, we're not perfect, etc. But I was very, very, very encouraged. I sat in on a parent meeting for my son's basketball team. There's a new basketball coach, and he made a comment. I am with your student for how many hours a week? You are with them 90% of the time. I can do what I can do to help prevent injury and all of that. However, I need your help with nutrition. I need your help with sleep. I need your help with keeping them,
Right.
optimal. And it was encouraging for me that we have someone who is thinking that way for these high school students because that's not usually the case.
No, it's not. And I mean, coaching is a thankless job, and I hold coaches in very high regard. I mean, they're giving their time at that level. There's not a lot of accolades. We
Mm-mm.
can take the pro and the collegiate game out where millions of dollars hang in the base.
Right.
That's a different animal. But the high school and youth coach,
Yeah.
they're there and they're volunteering their time, and it is refreshing to see a coach
Yes.
address those things because usually it's X's and O's. Make sure you're getting your kids to practice on time, this
Yeah.
kind of thing. I get asked by parents all the time. They're like, "Hey, will you come out and talk to my, fill in the blank,
Yeah.
soccer team, whatever?" I said, "I would love to. There's only so much bandwidth I have to go out and talk." And the
Sure.
biggest thing is the coach going to be receptive to that?
100%.
Um, it's a tall order today to look at what we're expecting coaches to do. Certainly, we want to be forging sportsmanship, teamwork, but we have to
Right.
look at, especially now, athletes are being forced into year-round sports. And I mean,
Yeah.
I was a year-round athlete. It looks different when I grew up. I played football, I
Yeah.
swam, baseball. It's a different sport each season coming in. I wasn't on 25 travel teams.
Right.
You one season into a next, you had time to recover. So even though it was a 12-month a year thing, generally
Hmm.
speaking, we weren't redlining it all the time. And now we're taking these kids and we're giving them a pro athlete schedule
Yeah.
on an undeveloped body,
Hmm.
and they're incurring injuries that we didn't see 20 years ago at that young age. And you also have all these coaches that probably aren't communicating and don't know how many other teams that these young athletes are on. So when you have a coach like that who tries to get the parents onboarded in a partnership, I think that's highly commendable. Um, it's challenging, and I think kids aren't going to want to hear the things that are good for them. Oh, mom, you're mugging me about, I didn't go to sleep. I want to be up, whatever. They're not going to understand it and appreciate it. But our
Yeah.
job's not to be their best friend at that level either. It's to just kind of try to instill
Right.
that little bit of repetition over time so that
Right.
when they do get to become young adults and they're in college, they're not hearing it for the first time that, hey, you need to be prioritizing exercise,
Right.
recovery practices, make sure your nutrition is good, sleep, all these things.
Yeah.
Uh, and I think the time to do that is at an early age and just slowly trickle it in over time.
Yeah,
Yeah.
absolutely. Like I
Good
said, my
approach.
kids get really annoyed with me, but I'm
That
fine with
probably means you're
it.
doing something
I'm
right.
fine. During that parent meeting, it was so funny. The coach said that, and I literally, like, I elbowed him, like, see,
Yeah,
it's
that's
not just
right.
me. Your coach needs you to do it.
That's right.
So there you go.
And I think if you have the alignment between the coaches and the parents,
Yeah,
now it's that repetitive where, you have that strength in numbers kind of thing.
for sure. For sure. They're not just
Whereas if
hearing it
it's,
from mom and dad, they're hearing it
that's right.
from
That's
their
right.
coach.
Yeah.
Absolutely.
Yeah.
And one other factor that you don't really weigh into all of this, especially we're kind of talking about the youth sports arena, is the burnout with this repetitive year-round schedule that's insane. So social emotion. We've got, some of the teams, again, we've moved a lot in the last couple years and the different areas that we've been in. But I will say the one thing that I've noticed in all of these schools, it wasn't just one particular area, is you've got less and less kids going out for their like high school teams or their school teams. And it's really interesting to me, and my opinion only, it could be that burnout factor of all these other things that we're doing outside of that, the travel, the AAU, all that stuff.
Yeah, I think it's a combination of things. I think part of it is uh, the competitive nature. I think because of travel, fill in the blank sport,
Hmm.
we've raised the bar so high that the average athlete now probably questions whether they're going to be able to make their high school varsity team,
For
you
sure.
know. And so now they're looking at, well, I don't want to play freshman, I don't want to play JV. Maybe I'll just go over here and play rec league because I can hang out with my friends. I know they're not good enough to be able to make the varsity team. So there's a little bit of that,
Yeah.
and Malcolm Gladwell talks about it in Outliers. If you were born between, I think he says January and March, because they're so much older given the school year,
Hmm.
they tend to get more playing time. And they did a lot of studies on NHL players, and they found that, by the time they were in whatever age group, 9 to 13, they had had so much more playing time because of the physical development. I mean, you take a kid at
Yeah.
8 months ahead of another kid, that might as well be 2 years in physical development. So there's that part of it too. And then there's just, the competition for other hobbies,
Yeah.
and I do think burnout is a big piece of that pie. It's certainly not the only thing. I've seen it at a very high level. I've seen athletes in my office, and I'm not saying they're feigning injury because originally they came in and they were injured.
Hmm.
But as they start to get better, and we get them better pretty quickly,
Right.
we've got great tools to use, and they're young, they respond well.
Right.
Now all of a sudden it's like, ooh, I don't have that get out of practice card. So what do they do is they start letting on that they're hurting more than they are. To where there's been times where I've had to have conversations with the patient, with the student athlete,
Hmm.
and start asking about, hey, are your friends having a similar issue with this injury that's not responding? Or it kind of goes from one thing into the other. And you always have to be thinking about, am I missing something as a physician? You always have to take what they're telling you at face value because there's always a reason why. But I have seen it where it became pretty obvious because we had exhausted other resources. And then when you talk about making a referral to a specialist, all of a sudden things get better real quick over
A
the course
real
of a day
bouncy
or two.
then.
Yeah. Or the coach gets involved and they're gonna, hey, maybe we can't play in that tournament because we don't want to
Gosh.
risk future injury. And all of a sudden the athlete's like, yeah, no, everything's good. I'm like, wow,
Yeah.
you made a turnaround in 24 hours. So I think there's that part of it too, where
Sure.
you have to be cognizant of that because I get it. Coming to my office for 30 minutes was a break. You got to skip one of your three practices today.
Right.
Um, it's important, I think, for parents to look at. We're stealing the childhood away from these kids. And
Yeah.
uh, I heard Mike Boyle say recently that when you look at the people who are advocating year-round sports are usually the people who are making their living off year-round sports.
Sure. Absolutely.
Just
Absolutely.
the reality of it.
My husband and I have had many, many, many conversations about this. Again, we're in the sports world. Um,
Yeah,
that's where they do their recruiting is at these events, but our own children do not participate. Uh,
yeah.
it's it's wild. It's the wild, wild west.
It's so much different than when I remember growing up. I really feel bad for these young athletes because it's a lot,
Yeah,
especially if you're a kid that has that competitive drive.
sure.
That you can't be half in anymore. I mean, you
Right.
really got to be all in, and I do think that leads to burnout for a lot of these kids. They
Sure.
they want it, they want it, they want it, and then they get to a point where it's just not sustainable,
Mm-hmm. Mm-hmm.
and then you look back and you're like, how many years of your childhood did you really lose chasing that dream of getting a Division I scholarship or
Right.
yeah.
Yeah, it's interesting. Like I said, it's a dynamic conversation for sure. Which leads me, I guess, to my next question. If you do want peak body performance, where do you even start? Where do you begin?
I mean, I think it depends on how you define that, you
Hmm.
know. So I think we have to put it in a context and, are we talking about an elite athlete?
Let's not talk about the elite
Yeah.
athlete. Let's talk about the everyday person who
Yeah,
just wants longevity
yeah,
and
if you want to just be the best version of yourself, and we
yeah.
always, joke about getting just a little bit better each day, right? Some people say just get 1% better each day. I mean, really, it comes down to defining what does that look like for you, the individual, right?
Hmm.
I think we need to set goals. A lot of my patients probably wouldn't consider themselves athletes, but they're marathon runners or they're competitive pickleball players. In their mind, that's just what they do, and they still don't consider themselves athletes. So, I think for a lot of people, it's always good to have something on the calendar to chase. Thanksgiving's coming up. Could be a turkey 5K,
Hmm.
or a turkey trot. For some people, it might be a half marathon. But I think it's important to sit down and look at what does that look like for you. It could be somebody that wants to lose 100 pounds.
Wow, yeah.
I've seen it happen, right? Um, that gets into the realm of that's a much more complex discussion because now you're talking
Absolutely.
about are they going to go on a GLP-1 agonist to help with weight loss? What are we doing in terms of strength training? But um, and I talk about it in my book. Um, Dr. Attia put out what I think is probably the best version of a framework for exercise, and it's very simple. It's comprehensive. He talks about the importance of doing stability every day, which I
Mhm.
agree with. I mean, it's got to be there. Strength training, we should be incorporating some strength training. And if you're new to that, it doesn't have to mean hours in the gym. It means a couple of total body workouts a week. Could be kettlebells, probably not a lot of machines, just getting some basic strength training, some
Mhm.
pushing, some pulling, some squatting. That can start with doing air squats. Then we need to move into looking at zone 2 cardio training. That gives us that aerobic base, getting on a stationary bike for 40 minutes to an hour.
Right.
In zone 2, there's a calculation for it. It's 180 minus your age, but that rate that you can carry on a conversation, but you're at a physical exertion level.
Right.
And then we should be doing yoga once a week, if not more frequently. And then the last thing in there would be a high intensity interval, which is really getting towards training for VO2 max. That's a well-rounded, I'm training for optimal human performance. Now, depending on your lifestyle and your profession and whether you have kids or you don't,
Right.
on that spectrum, there's going to be concessions we're going to have to make, right? For some
Right.
people, the gym is non-negotiable. They're doing 4 days of strength training a week,
Hmm.
non-negotiable. They'll skip a couple of zone two cardios. I should also put rucking in there because I think people, just the benefits of rucking are amazing for both men and women.
Yeah.
Once a week, I use it as a recovery workout. Um, I think it starts with understanding what the framework looks like and then reverse engineer where are you starting on that spectrum.
Right. Kind of
You know,
meet them where
I
they're
had a
at
good
and then
friend of
build from
mine over
there.
the last year went through this trek of, I don't remember the exact number. I would say 75 pounds they lost.
Wow.
And it started just getting into the gym and just getting on a treadmill and walking,
Just moving, literally
just
just
moving.
moving.
I mean, look, if you are doing nothing, the hardest part of you getting going again is going to be getting over that mental inertia because you're going to make amazing gains. Your body is just ready to see these changes happen.
Begging for it.
So yeah, once you start getting some momentum there, and after a month or two, we could start to, increase the amount of walking. We could start to add some strength training in there, some biking. Um, this person lost all that weight without going on a GLP-1, which is amazing.
Yeah, absolutely.
Um, yeah.
Would your goal be for a patient who does want to use a GLP-1 for that not to be a permanent solution?
100%. And my concern, and I had a patient over a year ago, somehow that was missed on the initial intake. They didn't put it down on their intake form that they were on a GLP-1. A few weeks into treatment, the patient just said to me, "Hey, I have a thought about what might be going on. Can I share that?" I said, "Yeah." Because a lot of times patients are the best source of information. Sometimes when
Sure.
you ask them like, "What do you think's wrong?" They'll look at you like, "Well, that's why I'm
You
here."
tell
Like,
me.
yeah, you're walking around in your body for 24 hours a day for
Yeah.
however many years you've been on this planet. And so this guy says to me, he goes, "I've been on a GLP-1 agonist for 3 months and I feel like I'm getting weaker." And I'm like,
Ooh.
"You are." Um, there are inherent risks there because he wasn't doing enough strength training to offset that he's not eating, not getting enough protein. It's a bigger issue for women, in my opinion.
Yeah.
I think short term, these are amazing meds that can be used, but we need to be talking about, are we getting enough protein intake and
Yeah.
are we strength training to mitigate the side effects of, at the end of the day, the biggest one, in my opinion, is muscle loss.
Right.
We need to be mitigating for that. Um, but I'm not opposed to it, especially if we're in the really morbidly obese category. We've got to do
Sure.
something. And I get it. When you're that overweight, orthopedic issues become a problem.
Right.
How can you tell somebody to go out and walk 20 minutes when they've got excruciating knee pain or
Right.
back pain or hip pain? It's a real issue.
Hmm.
So I think short term, we need to do what we need to do. Uh, I think all options should be on the table, but we should also look at the inherent risks to those treatment options and try to mitigate what we can.
Right. And I think that's where the conversation then comes in when you even start working with somebody like, look, this is what we're going to do temporarily, but the goal needs to be
Yep.
to, okay, lose a little bit of weight, get you more mobile so that we don't need these drugs. And I don't think those conversations are really happening. I feel
I
like
don't
a
think
lot
they're
of people are
happening.
like, okay, this is a really easy fix. I'm going to be on this forever. This is going to be great without really kind of knowing the risks or having that goal in mind of, I don't want to be on a med forever because
And
that's
this
not
is
really
where, back to a collaborative approach,
right.
that may be a long-winded conversation, meaning that conversation probably needs to take place over more than one visit.
Oh, for
Face
sure.
it,
For sure.
doctors don't have the time because we're
Yeah.
having to see so many patients a day. So if I'm a primary care doctor and I'm prescribing a GLP-1, I'm going to make that recommendation that the patient get with a clinical nutritionist, and then they can have that
Yeah.
conversation on, hey, here's our short-term, intermediate-term goal. We want to try to be on this for 3 to 6 months.
Mhm.
Here's working backwards. How are we going to get off of this thing?
Right.
And then you have the ability to delegate that conversation to another provider
Sure.
And then, by the way, let's circle back between the nutritionist and the primary care doctor to collaborate on what was said and to make sure that everybody kind of knows the left hand knows what the right hand is doing. And I don't think that that's happening enough in medicine
No,
today.
no, no, it is
And if you
not.
have a patient that understands their ultimate responsibility for self-advocating falls on them,
Hmm.
then they can go a long way to mandating that those conversations take place. Hey, thanks, Dr. Jones. Appreciate the prescription for
Yeah.
this medication. Is there a nutritionist that you can refer me to? I'd like to, you know, but patients aren't having those conversations generally.
No, and I think you and I were talking off air. That's the whole reason that I do this podcast. We talk about a lot of different things, physical health. I've had athletes on other areas of conversation, but I think the whole goal is that people need to understand that they are their own best advocate and um, they have autonomy in this. I mean, they are in control here.
That's
So,
right.
a big piece of that is knowing what to ask for. And I don't know that there's necessarily all that information out there, which is again why I have these conversations. I certainly did not know that when I was going down this route of trying to deal with a chronic issue that A, nobody could diagnose for a very long time, but then B, when I got the diagnosis, was not a pleasant experience. It was not a way that I wanted to be treated or handled, and it was not. It was a grim outlook, I guess. Grim in the sense that I did not want to be medicated for the rest of my life or have an organ removed or anything like that. That was just not an option in my book. But I don't think people know that they have options.
Well, that's just it. I mean, I think, the less you know as the patient, the more beholden you are to your physician. And I say the quality of your health, it really comes down to a few things. The
Hmm.
lifestyle habits and decisions that you make and the relationships that you have with your providers.
Right.
Um, I
So
think that,
building your team, but that,
yeah, building your team and healthcare in general, we've been guilty of just being experts at labeling things. A
yeah,
lot of times the label is inaccurate or it's only partially accurate.
sure.
And then patients are just given these diagnoses. Oh, well, you have arthritis in your knee, you need to stop running, right? All the way to the more egregious where we get down the spectrum of more significant diagnosis. And we're just giving people labels. And what that ultimately ends up doing for a lot of patients is it gives them a crutch. And now
Yeah.
they're tied to their physical limitations,
Hmm.
which ends up impacting their psychological well-being. And doctors, I think, need to take a hard look in the mirror and start advocating and fighting for their patients, pushing boundaries.
Right.
I don't fight for my patients' limitations. There are times when we have to keep them on a little restrictor because, they're overcoming an acute injury, but we
Sure.
need to be advocating for people to push beyond the boundaries of their current capabilities because that's where real growth is going to happen.
Right.
And in our healthcare system, it's sick care. Oh, Mrs. Jones, you have this. Hmm. And it's no wonder we rank like 39 in the world in terms of healthcare.
Right.
It's just sickening. And
Because
um,
people become so attached to that label that has been given to
that's
them.
right.
And a
That's
lot
right.
of
They
the,
become the label.
right. And so I worked as a health coach for a very long time for women, primarily with autoimmune diseases. And that was a lot of the work that we did was helping them let go of this label that's been slapped on and that's been kind of holding them back from getting better. I mean, yes, there is this thing. Yes, we're going to deal with it, but it can't be who you are. I had to overcome
Yep.
it myself again with my autoimmune diagnosis. And there's something freeing about kind of letting that go and just saying, look, I am going to do everything that I possibly can to feel good and to have some longevity in this. And, there's going to be some ups and downs and that's fine, but I'm in control here.
Yeah, I think ultimately, uh, there's certainly a small percentage of patients that just they get lucky to get in front of the right doctors
Right.
that just do all this for them. the overwhelming majority are patients like yourself that they don't accept the mediocrity of, well, this is just gonna how it's gonna be. They do their due diligence, they self-advocate,
Yeah.
and sometimes they have to fire their physician and replace them with another physician or physicians,
Yeah.
providers that are going to play more of a collaborative role.
Sure.
And I think if you're seeing a physician, look, there's nothing wrong with a physician who is absolutely confident in their ability and they
Right.
lay out exactly, here's what we've done, here's what we think you have. We're
Sure.
confident in this. Here's a course of action, and we
Hmm.
have your next steps laid out. That's one conversation. But if they're hemming and hawing and they can't define those steps, then you really have to sit there and look at it with the scrutiny to say, it's going to fall on me.
Yeah.
And your doctor should be willing to have that conversation with you because,
Yeah, I mean, it was interesting. The one that I fired, it was probably I'm actually grateful for her because it pushed me into a world that I didn't even know existed because I was so desperate for help.
yeah,
When she told me like, "Oh, there's nothing I can really do for you right now. We'll just wait until your thyroid burns out and then we'll medicate you for the rest of your life." That was
mm,
literally the conversation, and I
yeah,
was not willing to accept that, and it made me so angry that it lit a fire to where the next steps after that completely changed the course of my life and my family's life. I mean, we overhauled everything, everything,
mm,
everything. So I'm
mm.
grateful. I'm really, really grateful for her.
Well, that's a story that you hear over and over again. And they'll get to that break point with a physician and they're just like, I've got to pivot and look down another avenue. And it comes back to just that humility when you're a physician to know that you've exhausted your capability in front of a
Yeah.
patient, and hopefully you have the next step on speed dial and a
Hmm.
person you can refer them to.
Hmm.
And if you don't, you need to have that hard conversation with them and say,
Accountability.
unfortunately, I've done everything I can. Now, I'm not saying that's all that can be done.
Yeah.
Keep me in the loop. Let me know what you find, and then try to be an advocate for that patient because people people want hope.
Yeah.
And yeah, I mean, it's sad when you see people that just accept a diagnosis and they just accept like, well, I'm going to have this impairment forever. Um, it's difficult to watch.
Yeah. It really is. It really is.
So I'm glad that you
Um,
were able to break through out of that and get some
Yeah.
answers.
Like I said, I've
Um,
created a really, really wonderful team. I know we talked about building your own team, but I'm and I think I'm still accumulating too. I talk to some very interesting people. I have people
yeah.
like you on my podcast, other physicians that, I keep in contact with in other areas. And I think it's a great kind of pool to dip into when something pops up and I have a question. And it feels hopeful. Again, that you have somewhere to go and you're not just kind of floating out there with no help or no
Right.
conversation even. So bouncing ideas off of, that's a huge part of it as well.
Yeah, I mean, today it doesn't have to strictly be doctors and providers that are geographically close to you with the advent of,
I don't
we're able
have,
to communicate.
yeah,
So, and especially, look, for what I do, you can't get a haircut over the phone. I have to
no,
put my hands on people.
yeah,
But you can certainly consult and walk through and connect the
for
dots
sure.
for people. And so certain specialties and fields of medicine lend themselves very well to telemed and being
Absolutely.
able to have those virtual conversations because we can order blood work, we can order imaging, we can get
Yeah,
those results and look at them and then have a conversation. So it's an amazing thing to be able to have that network of providers that you can rely on when you need it
yeah,
and be able to bounce things off and say, hey, this is what XYZ physician told me. And then you can go to a specialist who's in the same field. Um, we did the same thing with my wife when she had ocular lens replacement, and she went to an amazing surgeon. And I have a friend who's an amazing surgeon. We got on a call, and her consultation, I mean, it was check, check, check.
Yeah.
Everything he said, he goes, I would have do the exact same thing.
Yeah.
So it's always good to get a second opinion, and it's
Mhm.
really peace of mind when they're in alignment,
Right. You
you know?
feel more secure in your in your
Right.
decisions there.
And if not, it at least causes you that moment of pause to say,
Yeah.
okay, maybe I need to do some more investigating to find out. And you go back to the original physician and say, hey, what about this? And I think the best doctors that are the most capable, they have the humility to be able to welcome a second diagnosis. They don't look at it as a deformation
A
of
slight
character.
on their
It's
reputation.
simply confirmation bias. And if we
Yeah.
find something different, now we have something to talk about.
Yeah, exactly. Well, to wrap up here, I like to ask people, practitioners especially that come on here, doctors that come on here, about a case that particularly affected you in a good way, somebody's life you changed, somebody who you always think about in the work that you've done.
That's tough.
You've worked in
But
a
I've
lot
been
of
pretty
different
lucky. There's been
arenas.
lots. Yeah.
Yeah.
There's been lots. Yeah, I'm trying to think. I had a case probably a couple years ago. I think I put it in the book actually. Um, well, I mean, one that comes to mind, believe it or not, is actually my mother.
Really?
And I mean, pretty simple as far as what I would concern, but to her it was like, life changing. She
Yeah.
she had a fall and like on the sidewalk and bruised her knee and anyway, pain didn't really get better, started to become more of a problem. She's noticing at work. Went to an orthopedic surgeon. They x-rayed her, told her she had arthritis.
Mm.
She was devastated. Shockingly, I was a little bit surprised that she took it as hard as she did because she kind of challenges the system.
Yeah.
I would have thought she would have been like,
Pushed back a little bit.
yeah. She took it hook, line, and sinker, like, oh my God. So she came down to see me in Florida, not strictly for that, but she was in town. And I said, let's get a look at your x-rays. So we looked at them. And I look at her x-ray, I couldn't see any arthritis at all. And so I said,
Interesting.
let me take a look at your knee. And she ended up, what happened is she had a soft tissue adhesion in and around the knee. It's a very common condition called IT band syndrome. And I did some active release with her and we got her using a foam roller. I only saw her twice over the course of, she was there for half a week. Next week, she's telling me how much better her knee feels. And I'm like, she's my mom.
Yeah.
Is she trying to just stroke my ego? And
She's
although
gonna
my
tell you
mom's
what
never
you want to
really been
hear.
that way, she's always been kind of the mom that's like, I don't really know why you're so upset. You didn't really practice that hard. That's probably why you guys got beat.
Yeah.
Uh, she always kept it pretty real. But I would say that was, that's a really good example of a patient who was given a label, very typical diagnosis. To her, it
Sure.
was earth-shattering.
Devastating. Yeah.
And now she's like, she should be like the poster child for foam rolling.
Yeah.
And it's just such a simple intervention. So that's one case that can come to mind.
Yeah.
Yeah.
That's amazing. Well, like I said, I skimmed your book. There's a lot of great information in there. Very, very easy to kind of read and utilize in your everyday life. Where can people find you, the book, and any more information?
Yeah. So Dr. Matt Fontaine, Instagram, YouTube,
Okay.
that's the handle. Website, drmattfontaine.com.
Easy.
The book is, I guess, everywhere books are sold. Amazon.
Perfect.
It's paperback, Kindle,
Okay.
Audible. It's on Spotify, plus numerous other audio book
Ooh, did
platforms.
you do the reading?
I
Did
did.
you? Did you? That's
Yeah.
awesome. I've always
Yeah.
wanted to like voice my own book if I ever wrote one. I think that would
I
be
did. It was
awesome.
fun. Yeah, we recorded it in studio. It was a great experience. The group I worked with was amazingly professional.
Yeah,
They took me under their wing and we had a lot of fun.
that's great. That's great. Well,
Yeah.
I will definitely add all of that to the show notes. What are we doing these days? What's next for Dr. Fontaine?
Well, just I've been splitting time between Virginia and Maine, so getting into clinical practice up here.
Oh, great.
We'll probably start doing some online consulting here in the next, looking towards the new year. We're probably going to put together a course online for primary care physicians, nurse practitioners, physician's assistants,
Love that.
all centered around musculoskeletal medicine, the who, what, when, and where,
Yeah.
and try to get them up to speed on how to build their healthcare team of referral specialists
Hmm.
so they can better manage these musculoskeletal cases.
Right. I
And
love when someone sees a problem or a hole and decides to create a solution. I think that's
yeah,
really admirable, and I hope that it has the intended effect for sure.
yeah, I do too. So big things are on the horizon. The group I'm joining, we're trying to take our model of integrative treatment and
Yeah.
branch that out and scale it because that's really the only way you can make an impact in healthcare
Right.
is grassroots.
For sure.
It's got to just come that incremental training people to that philosophy
Yeah.
and that methodology, and that's what we're looking at doing. And hopefully the book will be a catalyst for getting the word out there.
I love it. I absolutely love it. Well, if you add health coaches, call me. I'm always adding
Absolutely,
to my resume.
absolutely.
Wonderful. Well, Dr. Fontaine, thank you so much for your time. I will add all of this to the show notes, and I hope that book flies off the shelves.
Thanks, Brandy. Appreciate being here.